So we'd like to discuss eczema today because of the increasing incidence of eczema in the West. 20% of all children in schools nowadays suffer with atopic eczema, and our understanding of atopic eczema has improved year on year. We know a lot more about the postnatal skin and the fact that actually at birth our skin goes from being alkaline to acid, and this acid mantle that we have on the outer part of our epidermis is important for its mechanical structure and barrier function, as well as maintaining a microbiological environment such that it makes it difficult for infection to get through. And of course, when we have atopic eczema, we now know that there are a variety of factors that will impair that function. So we now know about filaggrin, we know that hormones have an effect, we know the environmental effects, etc. And so it's important for us to understand the barrier function of our skin in our treatment of atopic eczema patients. And I think we're all very good about applying or giving patients moisturisers when we see people with atopic eczema, and I personally see multiple patients who come in and say, I've tried all these creams, doctor, and none of them work, and they'll come with a bag full of things and every single one of them is a moisturiser. And what they don't understand is that is part of the treatment. It's not the whole treatment, but it is a very important component of the treatment to make the environment one that is less likely to flare. But they don't really get, or some patients don't understand, that the steroids are there to then reduce the flare and to be used for flare only, and the moisturisers are there to try to prevent the flare in the first place. So let's just talk about what makes eczema flare. And really, in broad terms, there are three main triggers. One is allergy, and I think if you're looking at a child who's very young, under the age of 1, who presents with severe eczema, allergy is a large potential component of their eczema. These are children who are not weaned yet or starting to be weaned, and they are most likely to be allergic to milk, cow's milk, nuts and eggs. This is now well established. There are other well-known allergens as well. There are top 7, which includes house dust mite, fish, soya, wheat, etc. But the top 3 remain milk, nuts and eggs. And the incidence of those change. So at some 2-3 years ago, milk was more common than nuts, etc. But nuts has now taken over. And what the importance of this is the fact that if you've got a child with atopic eczema and they're nut sensitive, we now know that that child is 80% more likely to develop asthma under the age of 5. So we have no predictive blood test that we can do, but actually that's really helpful in then the ongoing monitoring of that child for you as GPs, to make sure that whenever you see them that you ask about nighttime cough, etc., so that you know that you're not missing the early signs of asthma. But equally explaining to the patients, parents perhaps, to be looking out for signs and not to give them a false sense of security that because the child has one atopic disease that they're not necessarily going to develop another. So let's go back to steroids and steroid treatments of eczema, because to me this is important, and I think that actually a lot of messages often are given with steroids. I hear patients come along and say, well, the GP gave me this and then told me not to use it very much, and so as a parent I don't know what to do because they give me something as a bad guy. I assume that this is nasty stuff, I mustn't give it to my children. But actually what's really important is that steroids have been around for many, many years, and as such we know how they are useful and we know what the potential side effects are, and actually reassuring our patients that this is going to be very useful treatment. It will alleviate our patients' symptoms and reduce and get rid of the flare, so that the patients are then eczema free and remain eczema free if they're moisturised daily. That's the key. So how much steroids can you put on, and why are steroids really important? Well, we know that steroids work at steroid receptors on the skin, and we know that if you keep applying past a certain point, you can get all the side effects that we all know about, such as skin thinning. But what is that point? When is it too much? And I think that's the bit that I don't think necessarily patients will have a clear idea of when they leave a GP practice. And I think that one pivotal piece of research that was done a long time ago now proves that actually if you put topical steroids on the same piece of skin every day, it takes about 6 weeks before you get any evidence of atrophy, so skin thinning. So I think if you ask a patient to use a topical steroid to deal with the flare until the flare is finished within 3 weeks, then the likelihood is that the flare will have gone, the patient will be eczema free, but also you know, and the patient knows, that you're not overdoing it. And I think that that's really pivotal, because a lot of patients will partially treat their eczema. They'll do 4 or 5 days, they'll say, well, it's a bit better, but I'm scared of using this stuff, and so they stop. And then that's not good. So for me, it's getting on top of the flare. So other than allergy, what else causes a flare? Well, we know that infection is a big component of eczema, and about 70% of atopic eczema children will harbour Staph aureus in their nose. So they're nasal carriers of staph. And you can understand then all it takes is for a child to rub their nose and scratch their skin elsewhere before they've secondarily infected, or indeed sneeze on their hands and then scratch with their hands elsewhere, and before you know it, they're secondarily infected. And the classical story of a parent is they'll say, well, I put little Johnny to bed and he was fine, and in the morning he's covered in eczema, and it must have been the thing that he ate the night before. And actually, most of the time, it's actually staph. So one should always think of Staph aureus. I think if we go to the pictures now, you can see that this picture is obviously secondary infected. You can see there's there's golden crust sitting on the surface of the skin. However, if we look at this picture, it's not so obvious. But actually, if you swab both skins, you can both swabs came back as heavy growth of Staph aureus, and so I think it's key to swab the skin on a regular basis in order to make sure that you're not missing Staph aureus superadded infection. And why is that important? Well, we know that Staph aureus downregulates steroid receptors on the skin. So therefore, if you don't get rid of the infection, you end up having to use many more steroids on the skin than is required to get rid of the flare. And all of us want our children to be better with the bare minimum topical steroids, the parents and doctors alike. So for me, it's very important that swabs are done of the potential infected skin or flared skin, plus a swab of the child's nose, because if you don't swab, you don't know if they're a carrier. And often you might get the child better for that flare, but then it bounces back and one doesn't understand why it bounces back, and then that's why people start talking about allergy on a regular basis when allergy is not necessarily a component. So swabbing the nose, clearing the nose, if the nose is colonised with Staph aureus, with a local antibiotic to the nose rather than an oral antibiotic, I think is key. In addition, the third most likely thing to cause flare of eczema is stress, and we see that on a daily basis. So for tiny tots, it could be that they've got a 24-hour viral infection, and soon after that viral infection their eczema flares, or they're teething, or in our school-going age group, it's moving from one school to another, class to another, or doing exams. And all of these potentially stressful scenarios, be it physical or emotional, can cause flares of eczema. And explaining that to the parents and to the patient, I think is key, because this will allow them to understand their skin and therefore be one step ahead of the treatment and keeping control of their skin. So going back to making sure that the skin is well moisturised, it's key, I think it's important that we moisturise before the kids go to school, when they get back, and before they go to bed. Obviously, they need to be bathing once a day, and that needs to be a short period of time, not lying and playing in the bath for hours on end. So 5-10 minutes in a lukewarm water is sensible. A lot of people in London will talk about the fact that it's a hard water area and the effect of hard water on the eczema. And it's true that hard water does dry your skin to a certain degree. However, There's been some recent and useful studies coming out of Nottingham looking at water softeners and the effects of water softeners on eczema. And actually, we can't prove that water softeners are helpful in the treatment of eczema. So I think moisturisation is key and short baths are key in order to maintain good skin care. So therefore, in summary, I think moisturising the skin, making sure that steroids are used to deal with the flare until it's gone completely, and ruling out infection are key.